Good morning. I'm Lidia Schapira. I'm a professor of medicine at Stanford, and I'm delighted to contribute to today's educational session on health equity. My topic is called Integrating Community Networks in Cancer Research to Increase Diversity in Clinical Trials Accrual. Here are my disclosures. As we think about this topic, it's important to start with some definitions. Community is not just non-academic, but it's where 85% of Americans receive cancer care. Community is where people live and where many of our colleagues practice medicine. So as we think about engaging communities, it's important to think about all of the different participants in those communities, from those who are community health workers to patient advocates to community clinicians, whose word is really important because it's up to them sometimes to encourage patients or even refer patients for consideration of research. And it's also very important to understand their perspective if we're thinking about expanding network participation in trials by offering more trials on site away from academic centers. So engaging community clinicians in research has not been scaled in a sustainable way and really offers a lot of promise in very different and important areas. One is the idea of improving health equity overall, and by that I mean expanding access to care. And the other seen through the racial disparities lens in research to narrow the gap in enrollment of underrepresented minorities in research. Engaging organizations and advocates needs to be based on an alignment of fundamental goals and strategies. And the important thing about this is that this needs to start very early. We can't just drop trials into communities and expect people to come and enroll into them, but it needs to be based on established partnerships that start with the idea of understanding what the needs are of a particular community, engaging them in a multi-step process to understand needs, implement practices, and even make some important changes. So engaging community partners can address issues that lead to unequal access and unequal care and unequal outcomes. Community clinicians who are not affiliated with large academic centers may not recommend to patients that they participate or provide a strong endorsement, and may not refer because it's not easy for them or because they don't have expedited venues for doing so. Community oncologists may not have the training, incentive, support, and resources to offer trials on site, but may welcome the opportunity if they were provided with those resources. And for their part, academic clinicians may not discuss the option of participating in research with patients who demand an extra effort because perhaps they have low health literacy or low English proficiency, or they come from racial and ethnic minorities, and in some cases because of their age. One example of an institution that's published their report of a successful collaboration comes from the Duke Cancer Center, where they're partnered with community stakeholders. And they developed through this project PLACE, population level approaches to cancer elimination, a sequence of steps that they followed that were aimed at engaging the community partners and together identifying and aligning the assessment priorities. So they brought the community in even at the level of a needs assessment. They co-developed survey measures and strategies for dissemination and data collection. They implemented the survey, and then they analyzed the data and implemented strategies based on interest, community-derived priorities, and needs. So as we think about cancer centers and the expectations that they need to identify and assess the needs in their communities and increase clinical research participation, it's important to think about this particular strategy that involved all of their community partners early on, even at the stage of a needs assessment. And this was published a year ago. So we know that cancer disproportionately impacts traditionally underrepresented racial and ethnic groups, those who live in rural and agricultural communities, the poor, and the medically under and uninsured. So key to improving outcomes is to engage these community stakeholders in partnership to improve access to cancer care services. And as we think about those, from prevention to screening to treatment to survivorship and end-of-life care, then as we think about improving access and meeting people where they're at and increasing and expanding our services to support them, we can also think about the idea of opening up, the idea of engaging in research. Patient advocates play a key role. To quote Deb Collier, who is an important leader in the alliance groups and for patient advocates, she said that patient advocates can help sponsors identify and solve issues that patients have. So they bring a lot to the table. They need to be consistently involved in key phases of research, starting with concept development. Colleagues from SWOG published a framework for patient engagement with a roadmap for clinical trialists interested in bringing the patient voice more directly into clinical trial conception and development. And I must add here that it's important also to give the patient advocates a role in disseminating the results of research back to the community. MD Anderson on their website posts this idea that they rely on community scientists who are trained, who can quickly provide them with feedback that they can give to scientists as they're developing their clinical trial protocols. Involving community health workers in research is also important, and they have been instrumental in recruitment into prevention, biospecimen collection, and treatment trials. They can recruit through social media, in person, of course, increasingly in the pandemic and post-pandemic, this will not be in person, but they really are important in helping us to build trust in the research enterprise and raise awareness about cancer research, which then facilitates the idea of enrollment for people who are diagnosed and looking for treatment. The role of community oncologists is really important. They are engaged with caring for patients, they understand their community, and they have direct access to many of these people who are in aggregate those we define as belonging to underrepresented or minority groups. Memorial Sloan Kettering, for example, has published their experience in trying to reach out to community oncologists that started with a survey of the community oncologists in their own network to identify opportunities. That led to direct discussion between investigators around areas of common interests and exploration of how they could collaborate. And this led them to have a much better understanding of how feasible it was to open trials in community and to identify suitable protocols for this purpose. Investigator-initiated trials can also be deployed in the community. And again, Sloan Kettering has published their experience working in this area in radiation oncology. And they describe, again, the series of steps that they took in order to make this possible. They describe their implementation strategies at community sites, and it required an alteration in the incentive structure, building a coalition of physicians around a common interest, practice changes designed specifically to increase accrual into trials of minority patients. Patient navigation is a studied and intervention that provides really a service at all different stages of the cancer care continuum. There's a compelling case that we can make for involving patient navigators to increase patient screening, adherence to treatment, and cancer care. And I'd like to call your attention to the work done at the University of Alabama and published and led by Dr. Fuad. Now, they have a very strong patient navigation program that addresses many aspects of care. But through this project they called Impact Increasing Minority Participation in Clinical Trials, they specifically studied how patient navigators can affect or impact on accrual to clinical trials. So let me walk you through what they did. They identified 424 African-American patients with cancer who were referred for care. Of those eligible for clinical trial, and there were 378, 304, 80% enrolled in a trial, and 272 or 72% consented to receive patient navigation support. Of those receiving patient navigation support, 74.5% completed the trial, compared with 37.5% who were not being navigated. The difference in retention between the two groups was statistically significant. So in summary, the participation of African Americans in therapeutic cancer clinical trials increased from 9 to 16%. And I'm showing this to you here in a graphic style, showing that there was a very early improvement that was not only sustained, but kept getting better as a result of iterative changes they made to their intervention. And this was published in 2016. So from a clinician and practice level perspective, there need to be some changes. We need to shift people's awareness from just being saying that they recognize that there are disparities to being ready to change. And this means understanding the role of biases, cognitive biases, implicit biases that may pose a barrier to us reaching out to patients and actively making the changes necessary to enroll underrepresented minorities into trials. We need to implement individual, team, and institutional level interventions to address the root causes of inequities. This is not just about research, this is about access to care. And this can be done intentionally. There are now some short anti-racism trainings. There are communication workshops, including some that I'm particularly fond of because they provide a more nuanced understanding and shift our attention from thinking of cultural competence and mastery to more of a idea of being self-aware, being lifelong learners, and being more humble about what we know and we don't know. That would increase our ability to communicate effectively with people who come from a different culture and who've had different life experiences. Language interpretation services for patients with low English proficiency is key if we really are serious about enrolling some of these diverse patients. And patient and family-focused educational materials need to be changed and made more patient-family friendly and patient-centric, including the consent documents used for trials. Health literacy is really important, and I would like to recommend that you look at this publication from the National Academy proceedings of a workshop held in 2020 that makes a very strong case for health literacy as an ethical imperative in clinical trial research, and provides many very useful and very simple measures that can be implemented to improve health literacy. And very importantly, the idea also is to make informed consent more patient-centered. I mean, we know and have analyzed, and people have published over the years, the fact that these consent forms are not within the reach or understanding of most patients, and certainly not those who have low health literacy levels. The readability of informed consent forms in cancer is roughly around 10th, 11th grade or higher. We had looked at these from published trials, including trials that have specifically analyzed this, looking to see if things had improved over time. But I think we just keep reminding each other that the problem exists, and there don't seem to be many interventions addressed to really redress this, which is a shame. So in summary, in order to think about increasing the representation of people from diverse communities and those who have been underrepresented in research, I think it's important to build networks that are oriented towards care delivery and research and hold these two ideals together. We can implement strategies that are mutually beneficial to the partners, the academic partners community, or different community partners with each other, or community partners and some of the local groups, and provide incentives to all. We need to include the patient voice, patient advocates in planning and implementation of research at all stages, including the conception of research studies. And we need to provide researchers with access to diverse populations, resources, and provide them with communities that are ready to participate in research. And once the partners have been identified, even think about expedited mechanisms for consultation and access to both research and cancer care services. So in summary, we need multi-level staged interventions and a collective toolkit with measures and practices that can be shared across institutions so that lessons learned in one site can be applied to others. Thank you very much, and I would be delighted to take questions.